I'd like to introduce myself. I'm Rena Pasick from University of California, San Francisco, where I do disparities research and community outreach. And I am standing in for Karen Emmons, who was to moderate this session, but was unable to make the trip. So I hope you will help me out, because if you don't engage, it's going to make me look bad. My task is to connect you, the participants, with the panelists that you heard from this morning. And I just want to say that I really am excited about this meeting and the questions that we're wrestling with. It is really critical, given the statistics that we heard earlier today from Steve Taplin. So one way to proceed is, at our table, we started with the first question and then completely abandoned the list of questions, which often happens. And I'm just wondering how many tables had a similar experience. Okay, some of you are very obedient and follow the rules, and others kind of let it rip. My thought for this session is to let it rip. But I want to point out that there are 3 microphones right over here, down at the back in the center, and on the left. And I will start at the beginning with what is a level and how does it differ from a mechanism. And right away at my table, we had a lot of pushback on what is a level and the focus on levels. Because so many of the problems that we are wrestling with, the health outcomes that we're wrestling with, are very situation specific, where influences interact with one another in many dynamic ways that is different from one location to another location, and from one point in time to another point in time. And the concern was expressed that if we start to focus too much on defining these levels and developing some sort of framework, that we're going to miss a lot of the action, and we're not going to really be able to understand the mechanisms. So I would really appreciate if people would come to the microphones and help us begin to address this issue. And if nobody stands up, then I'm going to start calling on people, because I actually know a lot of the people. And I'll start with my friends, which is really, oh, good. Thank you.
Good morning. Jessica Chubak at the Group Health Research Institute in Seattle. One of the questions that we were playing around with about levels had to do with whether it made sense to, instead of having sort of one set of nested levels, to have more than one, thinking about levels of environment and levels of people. Because the current diagram seems to start with the individual, but then also move into levels of environment. And we wondered whether multiple overlapping sets of levels might be a useful thing to think about.
So how would you approach that?
Well, we didn't get that far. We just bounced around that idea that there were multiple things you'd want to capture, in addition to thinking about levels versus mechanisms of action.
So what you're saying brings to my mind is something that we talked about at our table, and that was an inductive approach to trying to understand what are the influences and what are the mechanisms. And really, and I think that's part of what Kurt Stange has talked about in terms of the use of mixed methods, where you can qualitatively look at an intervention or a problem and try to understand what the dynamics are without coming at it with a preconceived idea. And so, in fact, there undoubtedly are multiple levels within levels. And it's all about how you talk about it, and maybe you don't need to get hung up talking about levels so much as the influences and the mechanisms.
Do we get to push
Yes.
back? Okay. So let me just push back a little bit on that, because I think one of the things we heard from Kurt was the issue of communication and writing this stuff down in papers. And so I think I had a question for Kurt, but I think it's relevant to this. And so Kurt was noting that we don't report kind of contextual influences well, don't document them well in the literature. So if we don't come up with definitions of levels in some way, and I would just point out that it would be really very easy and very fast if you just adopt what we said. We can go right on to the next question, but absent that, I still think there is some need to begin to be clearer about levels and to report them. And so I would ask, I would push back on that and say a little bit, I don't want to get into that, well, it's all very complex. I think we need to push through that in order to be able to communicate exactly and consistently what each of us has done. But then I want to ask Kurt, as an editor of a journal, what latitude do you have, and what would you want? How would you want levels reported if you were going to begin to allow contextual reporting of papers in your journal?
So before I answer that question, I want to draw together the last two comments, which I think are really important. I think that it's very hard to depict in 2 or even 3 dimensions how things actually work in the real world of complex adaptive systems. And so I think the point that there actually are multiple interacting hierarchies is actually truer to the way things really operate. It also starts to get the edge of what we can hold in our brains. But the danger with, I like the onion model, the danger with a model like that, or any kind of unidimensional hierarchical model, is it tends to make you think that things are linearly related to each other. And that's a helpful way to think about things, but they're also linearly related and non-linearly related to other hierarchies. And when you were talking about the policy being a level and something that transcends and includes the levels, I think you were kind of getting at that. So I think that's a helpful idea, that we might think about multiple onions that are interacting. I've also been doing some work lately studying the role of boundary spanning and boundary spanners in promoting health. And I just read a book from the business literature recently that I hated the book, but I loved one really important point that it made. And that was, if you're trying to enable this kind of boundary spanning work, often first you have to actually define and sometimes shore up the boundaries. It's a very threatening thing for people to start working across boundaries if they feel insecure about their own boundaries. I think that's a helpful insight. So in depicting these complex systems, we do need to, it's helpful to create hierarchies, it's helpful to create boundaries, and that's a first step, and then we need to think about how they're complexly related. As far as the question that Steve just asked about how we publish these things, I would refer to the work that Russ Glasgow and Larry Green have been doing lately in trying to propose that we need to figure out a way to report external validity. And what they're talking about is the need for reporting context. And that's important for journals, and they got a group of editors together a few years ago that looked at this, and they've developed some recommendations. So if you just do a lit search on them, you'll find that. Brian Mintman was at that meeting, and no, he edits a journal as well. I think that we should, as journals, we should be more explicit about asking people to at least consider these other levels and report on them, just as we're considering different ways of knowing that include the subjective and the objective, and things that are at the level of the individual and the level of the group. So there are some emerging criteria for reporting studies that really ask us to report on context. And I would refer to the work of Russ and Larry.
One of the things we were discussing at our table is the fact that as a field, we're not comfortable and we're not trained to really explore and understand and describe context. And certainly if journals started requiring that, that would be a great impetus. But it gets back, someone mentioned training early on. This really requires people to know how to interact across disciplines. And but I'm gonna take the question that gentleman is waiting there. Did you want to comment?
Well, yeah, I'm Russ Glasgow from NCI. Since, yeah. Well, this is a good point. Point taken. A lot of adjectives used, but I think a related issue that for me that cuts across a lot of this, regardless of which level or which definition of levels we use, has to do with transparency of reporting. And there's a variety of, again, complex, interrelated reasons for this. But basically, I think our science could be improved a lot if, I'll just give a quick example, if we were more transparent about the process that went in for recruiting at like an organization or maybe even a community. Why did you choose this community? What were the criteria versus that? How many communities did you decide on? How about the organization or the healthcare setting? Why did you pick that one? Was it because they were the only ones that had an electronic health record? Why did you pick the particular settings or primary care settings for that organization? Because those were our friends that we knew or the people that were more. So, and then going down at each of those levels, why, what were the criteria behind it? And not trying just to be pejorative, but I think we would understand a lot more related to this issue that Kurt is talking about externally if we knew more about both the denominator at all those levels of the different levels and how generalizable each of those things were in the process going through selecting.
So Rena, can I just add to
Yes,
this
Martha.
discussion? Table 13 came up with sort of a suggestion along these lines is that, we have consort guidelines for publishing randomized controlled trials. Could we not establish similar guidelines for multi-level intervention studies and include everything that Kurt and Russ have been mentioning in there? And we would have to also somehow figure out how to work that into the page restrictions, the length restrictions in our, not only our grant applications, but also our manuscripts. And speaking as a deputy editor of a journal, it's something that we struggle with. But Deb Bowen and Wendy DeMark and I actually have an editorial in Press, correct? That actually makes the case that we should have consort-like guidelines for observational studies where we actually report the populations and the response rates and, all of that, retention rates, which we don't necessarily make sure that they're in our journal reports all the time, and I think that we need to do that. The second thing my table would like me to mention is that Steve and the panelists, you did a great job, I think, of getting us to think about a lot of these things. And we really asked the question, what is the definition of multi-level intervention? Does the intervention have to intervene at the 3 levels? Do you have to have a separate intervention for each of the levels? Or could one intervention have an effect on multiple levels? And do you have to then have that intervention, a different intervention for each level? What about measuring, baseline as well as outcome in terms of the effects of your intervention, as well as looking at outcomes across, multiple levels, et cetera? And I think those points need to be clarified, or maybe not be clarified, but discussed somehow in your point. So thanks very well. Table 13.
All right. Good points. We talked about this a lot. We set out a criteria of 3 levels of actual intervention in part as a paper tiger, just as a place to begin to look to see what we got, and also in part because the reality is there are lots of things that in healthcare that intervene at the level of individual patients and physicians or physician teams, and so we wanted to raise the bar a little bit and see has any and being aware of commit and assist and some of the other things. So we kind of set that up as a paper tiger. I think it is really up to the research community to decide what is the most important. And I think the issue of measuring multi-level effects, even if you were to intervene at one place with multiple, is a possibility. But as we look through the literature with the definition we use, we found even in commit and assist and others that were doing 3-level interventions, they were not measuring effects at all of those levels. So I think that the key piece is that you need to be measuring at levels. And I think to raise the bar and to begin to get at the problem, which is how does context affect implementation, you need to understand something about, in healthcare, the organization or the environment in which that organization is working in order to communicate to others, why did this work? How does it work? What do you need to do? If you put reminders in place, that means you have to change the information system. You have to get leaders to buy into doing that. And unless you've acknowledged that up front, then people wonder why reminders aren't used, because you don't have a reminder system and you've got to get the leaders to buy it. So it is, I think, quite possible to think about multi-level interventions if you're measuring effects at multiple levels, and I think it's up to the research community to begin to define which it is.
Hi, Bruce Rapkin from Albert Einstein College of Medicine in the Bronx. I wanted to broaden our discussion of levels in a couple of ways, and some of this picks up on Table 11's discussions, but some of it is just, my own editorializing too. I am really happy to have this discussion about levels, and I think that it behooves us as researchers to make the case for how we want to think about the ecology in which our interventions occur. And we have to, there's no one size fits all. And in fact, working in, for example, organizations, there are some organizations where certain strata of roles or activities exist and other organizations where they don't. They're just flatter. And we have to be able to make the case for what ecological system we're in and what structures exist and how they affect our patients or our populations that we work with. One thing that I wanted to actually emphasize is to get away from the idea of multi-level interventions as nested analysis of variance factorial designs, because I think that it's too easy to slip into this analogy of, well, the HLM kind of heuristic of this level affects the people in it in a linear way and they differ from another level, or even cross-level interactions. There was work in community psychology in the 70s by Isidore Chine, who talked about role by environment interactions. So different people experience the same environment in different ways depending on their connectedness or the relationship. So if you're a minority person in a majority serving institution, or if you're a long-time patient versus a new patient, or if you have some familiarity with a staff member or you don't, all of those things can affect the way that the same environment impacts you. So thinking about levels in an ANOVA kind of analog is probably going to be limiting in certain ways. And our table also talked a lot about bidirectional influences and arrows and feedback loops. So individual level, the responses of people, for example, to an innovation that's put into a care setting can affect the organizational level. And so we have to have an awareness of those reciprocal influences over time and the different ways that the environment can impact people. So I think that we have to, there's a real pull for this linear model thinking, and I think we have to back away from that and be more nuanced in understanding. I actually think the case analysis point that Jane presented in her paper was actually a very good way into this, to understand the functioning of different levels for different people in different circumstances. So.
Actually, I certainly would reinforce what was just said, but I did want to go back to the previous comment. Certainly, behavioral sciences have grown up with a rich tradition of formative evaluation and summative evaluation, as well as methods for rigorous process evaluation. And guess which one got the emphasis? It was the summative evaluation. And I think we not forget the wonderful standards and models we have for formative and process evaluation. If we think about them up front, what could go wrong, that could modify the intervention, but also tell you what levels you have to attend to in your evaluation. So I really think this whole look at multi-level interventions is a wonderful opportunity to go back and rethink some of those methods.
I would like to point out that it is possible, although I don't know now in this time of 12-page grant proposals, but back when there were 25-page grant proposals, it was possible to write entire R01s that were formative and process-oriented. But I do have to ask, isn't everything that we're talking about here, doesn't it run counter to the 12-page grant proposal? Because this is very complex stuff and I know that there's initiative underway to develop some guidelines for reviewers on mixed methods and for researchers as well. But this really, until 10 years from now, when we're more comfortable with all of this as a field, we're going to have to really justify how we're approaching these questions. And 12 pages is not going to cut it.
I think it's more than just 12 pages, because also the composition and the dynamic of what happens in the study section. And it's very, very difficult to argue against the biostatistician assigned to operate from a ANOVA framework that you are interested in mixed methods and this kind of thing, or the economist who approaches this from a straight linear regression format with a huge data set. And I think this is one of the things we were talking about with our little Machiavellian quote, how difficult it is to change this thing around so that we really can capture some of the issues that are really, really important if we're going to make a contribution here with these multi-level interventions.
I just want to comment on that one too. As a researcher who has then jumped over the fence and come to the other side, it's really, yeah, came in from the cold. It's really important for me as a person now at NCI to articulate how much you all have an influence on what happens by sitting on study section, by raising questions. But it's also, I think, important to recognize that I think the most important piece is get the science right and push the science. And if there's a scientific motivation and we begin to articulate it and we begin to publish, then things will change. But if we wait for the world to get right for what we want to do, it ain't going to happen. So it's really about our interaction and these kinds of discussions that are critical. We're listening, and yes, the authors will be affected, but people at NCI are listening too. And I think it is a potentially long process, but we got 17 years. If we can do it in 16, we're ahead. So we're starting, and I think it is about interaction. It is about articulating the science and the scientific need, and then we have to work with the community to move the science in that direction. So I guess I'm old enough to feel that it's okay to wait and to keep after doing the right thing, and then things will change.
Rena, I just had a follow-up comment on that. It occurs to me that a good model, perhaps, to follow that may help with some of these challenges is the one with the dissemination and implementation research initiative that has its own study section of, hopefully educated reviewers who are open to considering different approaches, different methods. I think even though that certainly has improved things, I do think if you look at all of the grants that have been funded through that mechanism, there still does seem to be a bias towards some of these more traditional approaches. So I think it's still a challenge, but I also think that could serve as a model for moving forward.
Okay, thank you. Ron Myers from Thomas Jefferson University Kimmel Cancer Center in Philadelphia. I have the privilege of representing some of the thoughts from the great Table 10 that is here. First of all, I also thank the panel for stealing one of our observations and thoughts relative to study sections and trying to make sure that at least there's an educational process in place to inform study sections that this is an area that they need to pay attention to and give some credence to, and in addition, potentially look at a possibility of setting up a new study section. In addition, I want to actually go back to a question which we tend to throw up our hands and say, well, this is just too damn complex. Well, there are companies, there are media companies that this is what they do. They take complex ideas and form them in such a way so the public understands them. We can work with those kinds of folks, those kinds of resources, and bring them into the process to help us communicate what we're about, what we're trying to do in these multi-level types of interventions. So that's something we haven't done. We haven't taken seriously. We haven't integrated them into that process, but they've done a whiz-bang job with pharmaceutical companies and so on. Why can't they do the same kind of thing with us? One of the other points that we raised in terms of trying to come up with some practical thoughts and suggestions along these lines is that wouldn't it be great if the NCI, the ACS, the CDC, and AHRQ, and anyone else would toss in some money to bring thought leaders together to develop models and frameworks and support the active development of work in that area. That would be an interesting process because, yes, we can individually go about the process of kind of developing models and frameworks, but if we had some kind of thought leaders come together to focus on that, that might be an interesting way of moving the field forward. There's also a question of moving this process of multi-level intervention research and then the active implementation of multi-level interventions forward. Doing the research is one thing, of course, actually implementing the interventions is another, and there are multiple stakeholders who should be considered as part of that process. All of the things that influence our everyday lives, how do they get integrated into this process of multi-level intervention, research, and implementation? Another question has to do with the clear identification of the various actors or agents of implementation. This relates to the point I just made. There are many players involved, such as if, and I've raised this in other meetings, if we want to increase colon cancer screening research, there are companies that manufacture colonoscopes who could be involved in the process of implementation of methods to increase colon cancer screening, for example.
Ron, I'm sorry to interrupt you. We have 3 minutes left, and so I wanted to give the panel...
So 15 seconds to the last idea, and that is we should be thinking about the use of social media to drive the multi-level intervention research agenda.
Responses from the panel?
Yes.
Okay.
Before we close this session, one of the things I would like to suggest, it seems to me that all the authors and their collaborators put a lot of effort into going through a very exhaustive review of the literature. I've heard from good sources that the JNCI papers are going to be 12 pages or maybe even less. In that case, I wonder if it would be possible for the authors to put up a URL or a couple of URLs that would be supported on the NCI website so that we could go, for example, it sounds like Kurt's group did an exhaustive amount of research, and work, which is not going to get into probably 12 pages unless it's very tiny print. It would seem to me that we ought to try to have some place where we could put these more detailed expositions up and reviews so that people who really wanted to go in and comb through them at a bit more detailed, fine-grained level could do so. So I would like to suggest that somebody at the NCI think seriously about that.
Thank you for that suggestion. We, the manuscripts are targeted at 4,500 words for the publication, but there also are links, so we can think. I can take the suggestion well, and we can think about links to a website. They're very interested in that kind of work, and allowing more access to more information than we can put in 4,500 words. So that's a great suggestion.
We're down to our last minute. Any closing comments for this first session from the panel?
Yeah, I had one thought. You know, we talk about the difference between the research part and the implementation part. I recall several years ago, and I think now HRET, the Hospital Research Educational Trust, is still operating with something that Howard Zuckerman and Steve Shortell started, in which they brought together fairly large, innovative CEOs in hospitals, Henry Ford, Intermountain, Kaiser, and so forth and so on. And these people generated some interventions that they were proposing and some problems that they were proposing. and they put out an RFP to a group of consortium universities, researchers, and they responded to that. And I think some very productive work came from that kind of thing, but most importantly was a dialogue between the people who actually run these organizations, who implement these kinds of things, and the people who do research. And I'm not quite sure current status of that. I think HRET is currently doing, but I think it might be worthwhile thinking about as a model by which one could implement some of the things we're in fact talking about.
So the quote of Machiavelli in the beginning referred to a new order of things, and it sounds very much like that is what we're all about here. We have a lot of hard work in this conference and in the days, weeks, months, and years that follow. So it's a privilege to be a part of this. Thanks to the organizers.
Thank you. Good job.